Hello, everybody, and welcome to the webinar this evening. Thank you so much for joining us. The topic today will be on the role of stents and the management of cholangiocarcinoma. And my name is James Badman, and it's my privilege this evening to be moderating this session. My role is to make sure we stick to time, but also meet our objectives. And I'm also joined by some speakers today to help me do that. So we're joined by some healthcare professionals and patient representatives and Helen from AMMF. On that note, Helen, I will hand it over to you to do a quick introduction, and then I'll pass it through our speakers from left to right. Over to you, Helen.
Thank you, James. Well, welcome to everyone who's joining us for this evening's webinar. As James has just said, the title of this is Understanding the Role of Stents in the Management of Cholangiocarcinoma. And I should introduce myself. I'm Helen Morment, and I'm the Chief Executive at AMMF, the Cholangiocarcinoma Charity. So on behalf of all of us at AMMF, I'm delighted to welcome our speakers this evening, Dr. Christopher Wadsworth and Professor Sheela Jayaraman, and also our cholangiocarcinoma patient advocates, Kevin Roger and Andy Clay. Now, they're going to provide us with information on an area that's very important to many in the management of their cholangiocarcinoma. We're going to hear about the different types of stents, how and why they're used, and key points of importance to the patient. And we're also going to hear about novel research into ways to improve stents. So now I'm going to hand back to James, who will ask each of our panel to briefly introduce themselves, and then there are a few housekeeping slides before we get going. So thank you, and I hope you find this evening really informative.
Thank you, Helen. And we'll start from the left and work towards the right. So first of all, Chris, how are you? We've had a good day. And then secondly, if you could just give us a quick introduction, that would be great.
I'm very well, thank you. Had a good day. And my name's Chris Wadsworth. I'm a gastroenterologist, consultant gastroenterologist at Imperial College Hospitals NHS Trust, and I work mainly at the Hammersmith Hospital. And my subspecialty interest is in management of pancreatic and biliary disease and doing ERCPs and endoscopic ultrasound. So that's the bulk of my job. And I will be speaking this evening about the clinical aspects of stenting of the biliary tree.
Perfect. Thank you, Chris. And then Sheela, if it's okay, if you could give a quick introduction.
Yes, hello, my name's Sheela Jayaraman, and I'm Professor of Cancer Biology and Gene Expression at the University of Nottingham. And my interest is in understanding mechanisms for how cholangiocarcinoma develops. But today I'm going to be talking about new approaches for stenting.
Perfect. And then Kevin, I know, Kevin, this is your second webinar for AMMF, so you're a seasoned pro, but we will ask you to introduce yourself.
Yeah, thank you, James. So my name's Kevin Roger. I was diagnosed with cholangiocarcinoma 3.5 years ago. I've had chemotherapy, radiotherapy, I've had attempted surgery, and I'm currently on immunotherapy. And I have 2 metal stents that were inserted shortly after my diagnosis, and have had several stays in hospital due to biliary sepsis when they block. So looking forward to hearing everything that Chris has to say.
Thank you, Kevin. And then over to you, Andy.
Hi, my name's Andy Clay. I was first diagnosed with cholangiocarcinoma in 2018. I've had Whipple surgery, chemotherapy, went to stage 4, and then I was on a drug trial for a while, and recently I was discharged as an outpatient after 5 years of clear scans. Thanks very much.
Brilliant. Thank you, Andy. So again, thank you all of our speakers for joining us this evening. We have no speaker conflicts today, so I will flick over that slide. In terms of the session this evening, it will be 90 minutes. So we're currently working through the welcome part of the webinar. We'll then have 3 parts. The first part, kind of 2 parts really. We've got a presentation from Dr. Christopher Wadsworth on the role of stents. We'll then have a 10-minute presentation from Sheela Jayaraman to provide a research update. Second part will then be a moderated discussion with both Kevin and Andy. And then we will then open it up to the rest of the audience. So we have about 25 to 30 minutes for the third part, which is a Q&A session. We will then finish close to 7:30 this evening. On that note, so as I said, there will be a Q&A session. You can use the Q&A feature towards the bottom of your Zoom window. That's where you can ask a question, and then we'll work with the speakers to get all of your questions answered. If we don't get all of them answered, we will be following up offline, and we'll follow up with a report after the webinar. If you're experiencing any technical issues, please use the chat function towards the bottom of the screen, and then someone in our team will be able to reach out to you. The webinar will be recorded, so you can check out AMMF's website. It should be available about 2 to 3 days after this webinar. So do keep a lookout for it on the website if you'd like to watch it again. In terms of the purpose of today's webinar, the aim really, as Helen said, is to provide information on what a stent is and why they're used, and importantly, what the implications are for the patient community. This is the third webinar in a series of webinars for AMMF, and the first two are available on the website. I think the first one was on clinical trials and the second one was on molecular profiling. So, really good sessions. So please do check them out. And then again, as I said, there is a Q&A session towards the end. Please send your questions in throughout, and then we'll get there towards the end of the webinar. Thanks again, everybody, for joining, and I will hand it over to you now, Chris, to kick us off.
Thanks very much, James. So thank you very much for inviting me to speak, and I'm going to be covering some clinical aspects about stenting, which obviously is going to be aimed at the patient group. I appreciate that some people joining the call and some people on the committee this evening have got very personal experience of having stents placed, and I look forward to discussing any particular questions or personal experiences people want to share later. So if we can move on to my first slide, thank you very much. So as I'm sure everyone joining this webinar knows, bile is produced by the liver, which is the darker brown organ labeled 1 on the little cartoon here. Bile is produced by the liver continuously. So it's produced by the liver continuously 24 hours a day. And it's got multiple different functions, but key functions are excretion of toxins from the body. So they are excreted by the liver into the bile, which is then drained out into the duodenum, the first bit of the small bowel, and then that mixes with our food, and a lot of it is passed out in our stool, in our poo, and it's one of the ways that the body gets rid of toxins. It's got other functions. Bile also helps with the breakdown of fats and absorption of fats in our diet, but that bile is produced 24 hours a day. It's not only produced when we eat, and between meals when we're not eating, there's a little valve at the bottom of the bile duct, label number 4 on this picture, which tightens up and causes some back pressure, and the gallbladder relaxes, and so bile preferentially goes into the gallbladder, and then when we eat, hormonal signals are sent from the stomach to that little valve to relax, and to the gallbladder to contract, and so we get a boost of bile when we eat, when all of this is intact. So we can move on to the next slide, please. So in terms of cholangiocarcinoma, the reason why we sometimes have to place a stent is if the cholangiocarcinoma is affecting the bile duct, typically from the hilum, so where the bile ducts divide into the right and left liver, right the way down to the ampulla ovata at the bottom. So any blockage in those areas will cause jaundice. So that's when the bile can't drain out of the bile duct, it backs up into the liver cells and then backs up into the blood, and then you actually start seeing the bile pigments being deposited in the eyes, in the skin. It starts dropping into the urine as well, so the urine goes dark, and because it can't drain out into the duodenum, it's backing up into the bloodstream and out through the kidneys in the urine, the stool goes pale because the bile's not getting into the gut, so the poo goes pale. Now, when a patient has a cholangiocarcinoma or any cause of a stricture in the bile duct that causes jaundice, it is important that we place a stent. And illustrated in the picture here are some of the variety of different stents that we can use. Now, illustrated here, working from the top, there's a plastic stent. So that's a very simple plastic tube. It's got some little flanges. You can see the little sort of protuberances at each end of it, or about a centimetre from each end. Those are there to stop in one direction, to stop the like a barb on a hook. They stop the stent dropping out in one direction, and they stop it going up the bile duct in the other. So they keep it in a stable position. Ideally, the stricture, the narrowing in the bile duct is between those two barbs, so it can't drop out and it can't go in too far. Plastic stents are very, very cheap. Plastic stents are completely removable. They don't get stuck. Never say never, but they never get stuck. And they come in a whole raft of sizes. So you can get them from 4 centimeters long up to 14 or 16 centimeters long. So you can put them to drain a stricture just right at the bottom of the bile duct, or if there's a stricture going right up into the liver, you can use a really long stent. You can put them next to each other. You can put 2, 3, or even 4 of these stents next to each other. So if you're trying to get into different parts of the liver and drain them separately, you can use multiple plastic stents next to each other. The stent below that is one called an uncovered metal stent. And this is how it looks when it's been released, but when it's on the delivery system for insertion, it's compressed down. So it's longer, but it's very narrow. So it's just maybe 3 or 4 millimeters in diameter rather than 10 millimeters as it is when it's expanded like that. And when it's released off of the delivery system in the bile duct, it's like a mesh. It's a metal mesh. It's a nitinol alloy, which expands and opens up the stricture, so it actively stretches up the stricture. And typically the stents that we would use in the bile duct stretch up to 10 millimeters, so significantly larger diameter than the plastic stent that I just mentioned. You can use a couple of these alongside each other. You can release them next to each other if you're going into the right and left side of the liver. But importantly, uncovered metal stents are essentially not removable. So you can safely deploy them across the hilum of the liver, where that division is between the right and left liver as it comes down to form the common bile duct. But once they're in there, unless you remove them within sort of 24, 48 hours, they're essentially staying in there. So they are very, very useful dealing with hilar strictures where you've got definitive knowledge of what the disease is. So if someone has a cholangiocarcinoma that's been proven on biopsy, and an MDT, a multidisciplinary team meeting, has decided that the correct thing to do is to obtain optimal drainage of that hilar stricture, then sometimes 2 metal stents placed either by ERCP or PTC, and we'll talk about these procedures in a minute, is the correct way of draining that type of stricture due to cholangiocarcinoma. The next stent down is a fully covered metal stent, and a partially covered one is illustrated below. The principles are the same with these. So these are very useful for dealing with strictures that are below that division of the right and left main ducts. So in the common hepatic duct or in the common bile duct, because these stents have the advantages of the uncovered metal stent, of expanding up to a full 10 millimeter diameter. But they don't have some of the disadvantages. So they're removable. So you can put one of these in, leave it for 6 months, and then remove it, and they generally come out very easily. The other advantages is because they're covered with a plastic film, tumor ingrowth, so tumor growing into the stent, is much mitigated. So it's much harder for a tumor to grow. It can't grow through the side of the stent. So they tend not to block as much. They do sometimes migrate. So what that means is they sometimes drop out when you don't want them to drop out compared to an uncovered metal stent. But that actually is very, very, very rare. The difficulty with a covered stent is you can't place it in a hilar stricture, because if you put it up into the right side of the liver, it would block off the left side of the liver because it's covered. The bare metal stents, the uncovered metal stents, because it's just an open mesh, any bile ducts coming in on the side of it can still drain, so you don't block anything off, whereas a covered metal stent can block the other side of the liver off, which obviously is not a good thing. So that's a very quick overview of the types of stents that we commonly use. There are many, many different brands, lots of sort of little refinements that people come up with, but these are the basic principles, and that feeds into what Sheela will be talking about later. So next slide, please. So this is just summarizing some of the pros and cons of metal stents and plastic stents. So just to recap, plastic stents are often used for short-term relief or when we know that the stent will be replaced soon. They're easy to remove. They do block quicker. They've got a narrower central caliber, much narrower. So the cross-section of that drainage channel is much, much narrower than the cross-sectional area of a fully open metal stent. So they often block faster. So a plastic stent we would normally expect to last for between 2 and 3 months before it gets blocked. A metal stent we would expect to last between 6 and 12 months before it gets blocked. Metal stents are often used, obviously, in the contrary of those purposes of the plastic stent, but a metal stent is used for longer term use. Bile flows better. Generally, the jaundice gets better if you're able to place a metal stent. They can last longer, but the bare metal stents, the uncovered metal stents, you can't remove. But covered metal stents, if they're appropriate, can be removed. So next slide, please. So why might a stent be used? So as I already said, I think we're going to point number 2 first, because it's the most important one. So to reduce jaundice or get rid of jaundice. So some of the people joining us this evening will know this from direct experience. When you are jaundiced, you feel awful. You have fatigue, your appetite goes. That's one of the first things that goes. And itching, if you're unlucky, itching can be absolutely appalling. It can keep you up all night. It can be very, very intrusive. So one of the key functions of putting a stent in is to open that bile duct up, let the bile drain as it should, the way nature intended, down the bile duct into the gut. You have the digestive advantages of the bile being there. And it can take days, sometimes up to several weeks, for jaundice to get better, but the liver will catch up. It will catch up with that backlog, the liver will recover, and the jaundice will go. So that's the principal reason for doing it. So if a patient's got jaundice, typically we would need to get that jaundice better, if we can, before they can go on to have other treatments like chemotherapy. Sometimes if patients have mild jaundice, they can go on and have surgery without having a stent placed. But if the jaundice is severe or the surgery is not very, very imminent, then stenting to relieve the jaundice so that the patient can eat, can remain well, can regain some strength before their surgery is crucial. Before chemotherapy, it's almost mandated that any significant elevation of the bilirubin is dealt with, and the bilirubin is below at least 70 at most before chemotherapy can be considered. The first point on the list to help reach a diagnosis. So sometimes patients don't have overt jaundice, but we are going to go ahead and do an ERCP procedure or a PTC procedure, which we'll talk about in a moment, because we want to take a biopsy from the stricture, from the narrowing in the bile duct. And if we go in and we do that, we know that if we go into a bile duct that's going to be sterile before we start, any procedure, even conducted in the best possible circumstances with the utmost expertise, if you go into a bile duct where there's a stricture and you take some biopsies, there will be inflammation related to the biopsies, there'll be a little bit of bleeding related to the biopsies, and it's likely that the patient will then become jaundiced and develop an infection in their bile duct. So if we go in, even if the principal reason is to take biopsies, we would normally leave a stent behind to mitigate that risk, to stop that risk of turning a situation where things are under control. We've gone on in and done a biopsy. We actually make things, although we might get our biopsy, we might make the patient clinically worse. So that helps us, allows us to take a biopsy by placing a stent to keep things safe after the biopsy procedure. And the final block on this slide is about unblocking previous stents. So sometimes we put a stent inside a stent. So you'll remember I talked about one of the commonly used stents for hilar cholangiocarcinomas is a bare metal stent. If there is tumor ingrowth several months down the line that starts to block that stent, we can go in, do an ERCP procedure or a PTC procedure and actually put a wire through the middle of that stent, through the blockage, and then slide a fresh stent in. And it normally opens up very, very nicely, and you regain drainage of the bile and you get any infection or jaundice under control. So next slide, please. So here we are. So these are the 2 procedures I keep going on about. So ERCP, endoscopic retrograde cholangiopancreatography. So that's a procedure that I do. So it's done by gastroenterologists and some liver surgeons, HPB surgeons, typically, and some radiologists do this procedure. So this is all done through the mouth, which means, so that's why it's endoscopic, some of the tube into the mouth. And we pass that tube down through the mouth, through the stomach into the duodenum, which allows us to get to that little valve I talked about right at the beginning, the ampulla of Vater, where the bile duct opens out into the duodenum. The second procedure is done through the skin. So that's called a percutaneous, which means through the skin, transhepatic, which means through the liver, cholangiography. And we'll talk a little bit more about what that involves, but that's not done through the mouth. It's done through the skin in the side of the abdomen or in front of the abdomen. By the radiologist, by X-ray specialists in the X-ray department. Now, one of the sort of commonly asked questions we get is, well, which one's best? Well, a bit like which stent's best, in some circumstances, any of those stents is best. In different clinical circumstances, an ERCP may be better, or a PTC may be better. And that's determined normally by an MDT, so an MDT meeting where there's time to discuss these things. But the factors that affect it are local expertise. So sometimes in some areas, there's a great deal of expertise in PTC. In other areas, there's great expertise in ERCP. In some units, there's a combination of great expertise in both. But in different parts of the country, different parts of the world, the availability of the technology, the equipment, the skills to do these different procedures will be different. But more importantly than that is what's the right procedure for that individual patient, because the driving factor when in our unit and in the big UK centres, which of these techniques is selected, well, it's based on what's best for our patient at this time. And that's dictated by where their disease is, where is their stricture, where is their narrowing in the bile duct. How does it look on the MRI? How does it look on the CT? We need to look really carefully at these scans to plan what's best for this patient. Has this patient had previous surgery that means we can't actually get to the ampulla ovata? Is it possible to get there, with ERCP, or do we have to use a PTC? And also, how fit is the patient? An ERCP offers quite a lot of advantages versus PTC, but if the patient can't have sedation or an anaesthetic, then we can't do it. Whereas PTC can be done with much lighter sedation and is perhaps a little bit less invasive. So there are patient factors which really should dominate this in a developed healthcare system, rather than whether that technique's available or not. So next slide, please. So this takes us into a little bit more detail about what an ERCP is. So as I said, this is done endoscopically by gastroenterologists, or sometimes by liver surgeons or radiologists. It's a tube through the mouth. And it's done while the patient's sedated or under general anaesthetic. And one of the sort of quality improvements in the UK is trying to push more and more ERCP procedures towards deep sedation or general anaesthesia rather than lighter sedation, because we know from lots of research and from lots of patient surveys, and we may hear some stories this evening, that ERCP under light sedation can be very difficult for the patient. Many patients tolerate it fine, but not all do, and this should be something that isn't daunting for a patient. It should be something that is tolerable and comfortable for the patient. So once the patient's sedated, we pass a tube through the mouth and down into the duodenum, and then we're able to we place a wire up the bile duct, and then we pass a fine tube over the wire. We inject X-ray dye to make the bile duct appear on a separate picture we've got, which gives an X-ray picture of the bile ducts. So the pictures here just show that black tube, the endoscope, going down through the stomach into the duodenum, just being positioned opposite the ampulla just before we start trying to place a wire into the bile duct. So next slide, please. So in terms of preparation for an ERCP, this is something that came up in a nursing seminar that we did at the AMF meeting in the spring, is that sometimes teams on the ward, they know the patient's going for an ERCP, and they know what the general principle is, but they're not quite sure actually what's involved in the procedure. So in terms of preparing for an ERCP, what the medical team and the nursing team do is have a careful look at the patient's history in terms of any cholangiocarcinoma, but also other medical issues like heart conditions or respiratory conditions. Look at the medications. It's really important to check the patient isn't on a blood thinner, for instance, because if the patient's not had a pause from their blood thinners, it can restrict or even stop us doing any form of ERCP or PTC. It's really important that whoever's doing the procedure has got very good review and access to any CT scans and MRI scans, and patients will normally have had their liver function test, their kidney function test, and importantly their blood clotting and their platelet levels checked to make sure that we are aware of any risk of bleeding, and we can correct that before the procedure. And then this mentions some cardiac investigations that might be undertaken in a subset of patients who've got a history of heart disease, where we need to make sure it's safe for them to have sedation or anaesthesia. Patients are asked to be nil by mouth for 6 to 8 hours before the procedure. This is so the stomach is empty, so that we can actually see the way through with the endoscope. And secondly, so that if there's any nausea or vomiting during or after the procedure, the stomach's empty, and so no gastric contents come up during the procedure and potentially important. The position for a patient having an ERCP is a bit of an odd one. It's either Superman position or it's called the recovery. It was very similar to the recovery position. So the patient's half on their front, half on their side. And that allows us to have the best chance of getting the endoscope into a good position and have a successful ERCP. As I've already said, most patients in the UK, most ERCPs in the UK are still done with semi-conscious sedation, but increasingly deep sedation is being regarded as optimal, particularly in long or longer procedures. So next slide, please. So this slide, this picture here just illustrates a stent being placed in the bottom of the bile duct. So you can see the black endoscope there, the little wire that's disappearing off the picture up into the liver. And then this little metal mesh, short metal, bare metal stent has been released in the bottom of the bile duct. And this is opening up. This is actually a pancreatic tumor in this picture, but it illustrates the point. It's opening up that blockage that was causing jaundice. So during the ERCP, as I said, we inject dye, which defines any stricture, any narrowing in the bile duct. If we need to, we can stretch that narrowing with balloons. That's sometimes not necessary with the modern stents, but sometimes we stretch a stricture with a balloon to start with. We can take biopsies, we can take brushings to look at under the microscope to help diagnosis if that's not already been done. And we're not going to talk about it in detail this evening, but we can do cholangioscopy, which is where we put a second endoscope, a small one, through the bigger endoscope, and we actually slide that up the bile duct and get direct optical pictures of the inside of the bile duct. That can be really useful in patients where it's still not clear whether they have a cholangiocarcinoma or whether they have a benign inflammatory biliary stricture. Stents are pushed down through the endoscope. As I said, the plastic stents are just pushed down as they are. The metal stents are pushed down on a catheter release system, which you then push up the bile duct, and then the nurse releases that, and we control that under X-ray guidance as it opens up within the stricture and stretches the narrowing up. An ERCP, we would typically quote a success rate of 90 to 95% in the first procedure, successfully stenting the stricture. The complications of ERCP are not trivial. So the potential complications include bleeding, include making a perforation and an unintended hole somewhere from the sort of mouth downwards to the level of the bile duct, introducing infection into the biliary tree, or triggering pancreatitis. Because the pancreas, as you can see from this picture, the bile duct passes through the pancreas, and the pancreas is an extremely sensitive organ. So whenever you're passing any instrument or doing any procedure near the pancreas, you risk triggering an episode of pancreatitis. And that's inflammation of the pancreas gland. It can be very painful and it can be life-threatening. It occurs to some extent in about 5 to 8% of people undergoing ERCP. Generally, it's mild. It doesn't feel mild, it feels horrible, but it generally lasts for about 48 to 72 hours, and then it resolves on its own. But sometimes pancreatitis can be life-threatening. The other complications like bleeding and perforation are rarer, maybe 1% or less, and they can sometimes need surgery to fix. So these are not trivial complications, but still often ERCP, even with these potential complications, is the correct procedure for the patient to have. But that's why it's always important that that's clearly determined. It's the right thing to do at the right time in the right place. And then the complication rate is acceptable, I guess is the word, but it's counterbalanced by the appropriate benefits. So next slide, please. So this slide just summarizes the PTC procedure. So this is the percutaneous procedure for draining the bile ducts, normally undertaken in the X-ray department by radiology doctors. And the principles are very similar, but there's just a different way of getting into the bile duct. So local anesthetic is placed into the skin, and then increasing sizes of needles are used to puncture one of the small bile ducts at the edge of the liver, and then the wire is slid down through the liver and through the stricture in the bile ducts in just the reverse direction of what we would do at an ERCP. And then the similar sort of tools can be passed over that wire. So biopsy forceps can be placed and stents can be placed. So the tools are different, but they sort of fulfill the same functions as the techniques that I discussed in the ERCP procedure. This procedure is done normally with patients lying on their back, and the sedation often can be lighter for a PTC because there's no tube going through the mouth. So next slide, please. So as I said, the tools are the same, and the placement of the stent is analogous. The success rate may be slightly higher than PTC, but one of the potential downsides, which is mentioned on this slide, is that it often requires repeated procedures. So again, some patients joining us this evening may have the experience of having 1 or 2 PTCs and then having to go for multiple further procedures while wires are repositioned and then stents are placed. Some patients need 4 or 5 procedures. It doesn't mean that's wrong. It's just the nature of this technique and achieving optimal drainage of the bile for that individual patient. But it often requires more procedures than the ERCP would, but that's a very broad rule of thumb. Complications are quite similar. So bleeding, leakage of bile from the punctured bile duct, making a perforation unintended in a blood vessel or another structure, introducing infection into the liver, or even this technique, even though you might think they're a long way from the pancreas, placing a stent lower in the bile duct can trigger pancreatitis. And one of the risks of this procedure that isn't a risk of ERCP is because the top of the liver is very, very close to the lung, the needle can sometimes puncture the membrane that goes around the lung and cause a pneumothorax, which means collection of air around the lung, which can be dangerous as well. But normally easily managed, but you know, an unwelcome and sometimes dangerous complication. So next slide, please. So in terms of management after a stent, so you know, our hypothetical patient has been through the procedure we've discussed, and they've had a stent placed. What do they do next? Well, it's important to try and re-establish eating and drinking. Often the patients have no appetite for weeks before the procedure, and it does take days afterwards before that comes back. But trying to build up regular food intake is really important. Maintaining good hydration, starting to take gentle exercise as soon as you feel able is very useful for general condition and also psychological well-being. In terms of traveling, patients often ask about, well, what can I do with my stent? It's really useful if the patient, you know, most of the time their stent's fine where they're on holiday. Don't assume the worst, but to prepare for the worst case scenario, making sure you've taken a copy of your ERCP or your PTC report with you. Any clinic letters you've got that summarize what's happened to you can be really, really useful if you find yourself in a different hospital in the UK or in a hospital overseas trying to explain exactly what your situation is. Something else that we do for our patients is if they are planning to travel abroad, particularly if they're going somewhere where it might be harder to access healthcare, is if you have a stent there, it's perfectly reasonable to request a week's worth of a standard antibiotic to keep in your wash bag when you travel, so that if you're in touch with your nurse specialist or your doctor while you're away because you've had any issues, you're worried about an infection in your bile duct or your stent, you can just get on and take it under their guidance. Other general advice, we advise our patients to buy a thermometer if they haven't got one at home, because if you're feeling a bit unwell, we'll talk about some of the symptoms in a minute, but if you're getting any of the symptoms, perhaps early symptoms of infection in the bile duct or stent, having a thermometer there to check is your temperature up or not can be really, really useful. And again, you can sort of then pass that information on to your nurse specialist if you're speaking to them on the phone or exchanging emails. So if we can move to the next slide. So in terms of complications early after stent insertion, so infection related directly to the initial procedure would normally cause fevers within 1 or 2 days of the stent. It's very rare that you would get an infection that's related directly to the procedure anytime after that. Pain after the procedure is very common. It's not sometimes well explained to patients that as the stent expands in the bile duct, it can cause pain. It causes stretch on the adjacent liver. And although there are no true pain receptors in that area, that tension, that stretch can actually give quite a deep-seated pain in that area. Bleeding normally happens within 72 hours of the procedure. Very rarely it can happen later, but typically it would be within 72 hours related to an ERCP or PTC. And the symptoms that causes are vomiting of blood, which obviously most people would recognize that, but sometimes that vomit can be black. And sometimes the stool can be black as well, which may be not so intuitive of a sign of bleeding. Perforations after an ERCP or PTC, that's normally recognized very soon, if not during the procedure. But if it is only recognized afterwards, the typical symptoms of severe pain, normally within 24 hours of the procedure, distension of the abdomen because of gas distension, and sometimes even the sensation of gas under the skin. You can feel it crackling under the skin. But as I say, that's normally recognised during or immediately after the procedure rather than being a delayed complication. Movement of the stent, migration of the stent, really is covered by the next slide where we talk about stent blockage, because if the stent drops out, either it drops below or it moves up above the stricture, then the symptoms are the same and the management is the same. But typically it causes jaundice and symptoms of infection in the bile duct. And pancreatitis almost always occurs within 24 hours of the ERCP or PTC. It's not common at all beyond that 24-hour period. And that causes severe pain, nausea, going off your food. Again, it's normally recognised while the patient's still in hospital after their procedure. So not a delayed complication. So next slide, please. So in terms of stent blockage and infection, I would use these interchangeably, because if a stent blocks, it is inevitable. There will be a degree of infection in the biliary tree. And the same I would roll into this if the stent moves. So if a stent drops out or it moves up above the stricture, with the qualification that sometimes when people have had very effective chemotherapy or immunotherapy, actually sometimes the stricture has improved because the tumours improved so much, and actually their stent can drop out and actually they don't go yellow or get cholangitis. But that's just a caveat. But typically if a stent moves significantly, so it drops out of the stricture or above the stricture, if the stent gets blocked due to ingrowth of tumour or due to inflammatory tissue caused by infection or food going up into the bile duct, then infection is almost inevitable. The technical term for infection in the bile duct is cholangitis. That just means inflammation in the bile duct, but we use it to mean infection in the bile duct. And although the symptoms can be quite insidious and low grade to start with, maybe particularly if patients, knowledgeable about their previous symptoms, the urine starts to go a little bit dark, they go off their food a little bit and almost feel, oh, here we go again. This is a bit like when I first got ill. Those symptoms can be quite subtle and insidious, but often the patient is alert to them and recognizes them because it's like when they first got ill. As things develop, chills, fevers, flu-like symptoms, shaking uncontrollably, feeling really cold even when it's a hot room, and a temperature when you measure it. Going off food is really, it's almost universal. Most people, when they have cholangitis, just don't feel like eating. Even you can put their favorite food in front of them and they just turn away. They can't face it. So poor appetite, nausea and vomiting, jaundice, fever or high temperature, and sometimes a pain in the right upper quadrant, so in the top right of the abdomen. That inflammation, that distension of the bile ducts can give a deep-seated, very unpleasant pain. The priority, if this develops, if there is blockage of a stent, if there is cholangitis, is to start some antibiotics, because that can keep any sepsis under control by time, so that then scans can be undertaken, the stent function can be assessed on blood tests, on scans, and a repeat ERCP or PTC can be planned to either remove and replace or place a fresh stent through an old stent that's become blocked. Okay, next slide, please. So that's the end of my talk. So that's good. Sorry, I thought there was one more slide. So I hope I've given a good overview of the types of stent that we can use, the reason we use those stents, the techniques we use to put them in, ERCP and PTC, and then quite importantly at the end, particularly the medium to long-term complications of a stent. So blockage of a stent leading to infection in the bile ducts, and how that's managed. And the key things being seek help early, start antibiotics as soon as possible, get a scan so that we can see exactly what's going on, and then plan what the right strategy is for replacing or refreshing the stent that may have become blocked or moved. So I will stop there. I think I've run over.
Thank you.
Sorry.
Thank you, Chris. Yeah, full of really useful information there, and I'm sure the questions will start to flood in. I am going to ask us to hold the questions for now. We will go to the Q&A shortly, but we're now going to go to Sheela, who's going to look at the current research and some of the amazing work that is being done in regard to stents. So over to you now, Sheela.
Hello, thank you very much. Let's move on to the next slide. So what does the future look like for stents? Well, there are 4 directions really that stenting research is going in. So identifying new materials for stents, different coatings to block bacterial growth, trying to look at stents that can release medicines so that we can kill the tumor cells directly, different stenting procedures for improving methods for bile drainage, And then there are, of course, studies as well to see how people do after these different treatments. Can we have the next slide, please? Okay, so in a very, very unexpected but very nice thing is that the MMF have recently awarded my group some funding for a studentship so that we can try and apply some of our expertise to trying to make stents last longer and work better. And of course, the aim is to try and reduce the amount of stenting that has to occur for all cholangiocarcinoma patients. Can we have the next slide? And of course, Chris has very well outlined all of this, so I'll just very briefly mention that the purpose of stenting is to, of course, improve bile flow, to improve quality of life. Chris explained about the itching and the jaundice, and we know that ideally you want to be able to allow 50% of the bile in the liver should be able to drain freely. And what we're trying to do is to increase the length of time the stent is active within the body. The main three things that happen are that bacteria grow within stents and form biofilms that don't respond to antibiotics. And so stents can get blocked up with bacteria. And they also, associated with this is the deposition of different proteins and cholesterol deposits within the stent. And this with the bacteria is often known as sludge. And then on top of all of that, tumor cells also grow in and along the stents. Can I have the next slide, please? So I won't go into this in much depth because Chris showed us the stents very nicely, and we now know that there are plastic stents, there are also metal stents, and the advantage of the metal stents are that they are wider, so you've got better bile drainage, and this is particularly important for the patients with hilar cholangiocarcinomas. But the disadvantages are that they're a bit more expensive, they can cause inflammation, and one of the main disadvantages is that they do allow tumors to grow within the cell, the stents. And so the manufacturers have come up with the idea of covering the stents with a membrane, and that's really good because it does block the tumors from growing into them, but it does, on the other hand, restrict the amount of bile that can be drained. So bearing all of that in mind, next slide, please. Different groups, not our own, have gone on to try and improve the stents. And one of the things that they've done is to coat the metal stents. So SEM stands for self-expanding metal stent. To coat the metal stents with polymers. These are chemicals that can polymerize into long chains, and coat the stents with these polymers that can elute chemotherapeutics. So chemotherapeutics like cisplatin and gemcitabine. And these chemotherapeutics do, of course, kill tumor cells, and they have been shown when they're attached to a stent and to the polymer coating the stent, they can kill the tumor cells in animal models, but the ability of those stents to maintain the bile flow, the patency has not been assessed. And other scientists have coated stents with polymers that are impregnated with silver nanoparticles. And those nanoparticles are very good at getting rid of bacteria that live in the bile duct. And in animal models, they have been shown to improve stent patency, so the lifetime of the stent. But in those experiments, the effect of those nanoparticles on tumor cells hasn't been assessed. So with that in mind, our group have come up with some ideas about trying to improve stents further. So if I could have the next slide, please. So this is the vision for the work that we have a studentship, money towards a studentship from the AMMF. Myself and Professor Kevin Gaston and Professor Derek Irvin from the University of Nottingham are working together to try to make a better type of stent. Professor Irvin is he's a materials scientist and a chemical engineer, and Professor Gaston and myself are cancer biologists. So we're coming together to try and make, to improve stents. So Professor Irvin has identified biopolymers that are biocompatible, which means that they are able to be tolerated within people without causing major side effects. And he has identified biopolymers that will reduce biofilm formation. And he has used these biopolymers in urinary catheters to stop the bacteria that coat the catheters and give people with urinary infections infections. So we thought we would utilize this technology that is currently being commercialized, and people are using this now on stents. So Professor Irvin also knows about how to coat the metal stents carefully on the struts so that the coatings don't block the pores, and that allows the bile flow to be maintained. So we thought, okay, so if we can use the biopolymers to block the bacteria, make sure the pores don't get blocked, and then we also have a technique which is to make microparticles, which are shown on this slide by these yellow spheres. So we will attach microparticles with these yellow spheres that contain a drug that myself and Kevin have identified of late that can kill tumor cells. We'll attach the microparticles to the polymers that can kill bacteria. The microparticles will degrade with time and release the drug in a slow release mechanism, so that the drugs shown in blue as these sort of blue V's can be released, or some other kind of drug conjugates can be released with time at different time intervals to slowly be released to kill the tumor cells. So that we're hoping to do a 2-in-1, kill the bacteria and also kill the tumor cells. And at the same time, we were also, since we were going to be experimenting with these new types of stents, we thought we would also add some gold nanoparticles to the polymers, because they should improve the imaging of the stent, allowing us to visualize the stent better once it's in place. So those are all the things that we hope to achieve. Next slide, please. So we haven't started this project yet, and so I'll probably be able to tell you better how it's going to go in 3 years' time. But at present, our first steps, when we're coming to this big project with loads of different ideas about what we want to do, we have to break it down into little manageable bite-sized chunks. So I have some questions that we have in mind now. So our first thing is, can we grow any tumor cells on the stents and then try to coat the stents with the bacterial compounds that can kill the tumor cells? So that's our first question. So then our second question will be, can we identify the antibacterial polymers that will definitely prevent the growth of bacteria that are prevalent within the bile duct? So Professor Irvin has identified the polymers that will kill the bacteria that grow in the urinary tract, and many of them are very, very similar, but we have to show that we can definitely do it from the bacteria from bile duct. And then we've identified a drug that can kill tumor cells, but we need to know whether or not we can put that drug within these antibacterial polymer microparticles. And then finally, we need to know whether we can release that drug. So you can see we have to build up lots and lots of questions that we need to answer, and this PhD student will help us answer them. And I'll just show you a couple of things that we've done. So next slide, please. So just to show that we've started to grow tumor cells on the stents. So this is so that we can eventually try to treat them with drugs from the stents and try and kill the tumor cells. But I thought I'd just show you that we've made the first steps in testing how the cells grow on these stents. Next slide, please. This is a busy slide, but it just shows you that there are different types of drugs that are effective against different types of bacteria that grow within people and form biofilms and are often very antibiotic resistant. So some of these sorts of chemicals are the ones that Professor Irvin has been using for his anti-bacterial urinary catheter treatments. Next slide, please. And then we have managed to use some of those polymers to make microparticles within the laboratory with the help of Dr. Adams, another collaborator, and Professor Irvin. And that's where we're at. So we now next have to include the drug. And when the PhD student starts, that'll be one of the first things that they'll be doing. Next slide, please. And that's about it, really. That's all I can tell you at the moment. So we have some ideas, and unfortunately, science is never simple. You can have plenty of ideas. Some of them work, some of them don't, but we will be doing our best to try and improve the way stenting works. Thank you.
Thank you, Sheela. We will now go into our moderated discussion, which we've got 10 minutes allocated for. I do encourage everybody at home to submit questions. We don't actually have any at the moment for the Q&A, so please do get them in. But we will now go to our moderated discussion with Kevin and Andy. So lots of great information there, Kevin and Andy. Just any questions from you both that you'd like to put towards Chris or Sheela?
I have a question for Chris, if I may. In terms of the follow-up after having a stent inserted, some of the symptoms of what might be going, if there are issues, some of the symptoms sort of overlap. And from a doctor's perspective, how do you sort of know which one to zoom in on? And the reason I'm asking this is from my own personal experience. I had a lot of pain and discomfort after my first stent was put in, and the GI said, well, I had to put a lot of air in, and this is just air moving around your intestines that's causing the pain, and give it 2 or 3 days and it'll pass. But it was actually pancreatitis. So I went a couple of days at home in excruciating pain, thinking, well, it's just going to go away. So how do you sort of, from a doctor's perspective, decide which one of those symptoms when you've got those overlapping situations?
Yeah, that's a very tough question to give a short answer to. But obviously, experience, listening carefully to what the patient's telling you, about the intensity of the symptoms, the nature of the symptoms, and then their duration. And obviously, I don't know the circumstances of the situation you found yourself in, but trapped air will normally typically give discomfort as the patient wakes up, which should ease off over the subsequent couple of hours. And typically after an ERCP in our service, we would keep the patient for their first ERCP. They would be kept at least overnight. If they came to us as an outpatient, we would admit them for one night afterwards. And I would expect symptoms like that related to gas distension of the gut to ease off well before they were ready to go home the following morning, for instance. But rules of thumb are, as I say, the intensity of the symptoms, listening to the patient, associated symptoms like nausea and vomiting, which are very common in acute pancreatitis, having a low threshold for keeping the patient in hospital, doing the appropriate blood tests and an appropriate CT scan helps us sort out cases like that where you're not sure exactly what's causing the situation. But it sounds a little bit what's the word, knee-jerk, but if there's any concern in the 24 hours, 48 hours after a procedure like that, then doing a CT scan will generally sort out exactly what's going on, because a perforation looks very different from pancreatitis, which looks very different from infection in the bile ducts or the stent dropping out or some other complication in the immediate aftermath of the procedure. So I'm sorry I can't give you a straighter answer to that question, but I think it's complex, and there are multiple different factors to take into account: patient's observations, temperature, pulse rate, blood pressure, all of these different things.
No, thanks for that. I think I probably should have been a little bit more vocal, but once he gave his initial assessment and saying, well, it's all the air trapped in your intestines, I just sort of sucked it up for a period of time where I probably should have been a bit more vocal about the amount of discomfort I was in.
I think a lot of people are very stoic, and they tolerate an awful lot before they seek help, which it's human nature, I guess, and in hindsight. But you expect things to get better, don't you? You expect that slowly things are going to improve, and you take some paracetamol, you expect things to improve, and when they don't, then yeah, I mean, I think that one of the key messages we were keen to push this evening is you seek help soon. If they think there's something going wrong, then seek help. And little things, and it's not relevant to the situation you're in as much, but little things like having that thermometer at home, you can collect some information. A lot of people now have got devices at home that will check their blood pressure and their pulse rate, and you can, I'm not expecting people to become amateur doctors or nurses, but you can collect some little bits of information that can reassure you or reassure your care providers, your medical professionals, that things are okay, or actually things aren't going well, and that can be very useful.
Can I jump in there, if that's okay, Chris?
Sure.
That was really a really very interesting point that Andy's raised, and it's made me think again that we don't have enough information for patients when they're leaving the hospital after having a procedure. And I know we've talked about this, Chris, that we want to produce something at some point. But I think just in Andy's situation, do you think it would have been worth his doctor saying to him, well, this could be the air, etc., but and put a time frame on it? If this doesn't begin to improve within the next day, come back, rather than it will go away and then he's enduring a lot of agony for days. Would it be worth putting time frames on things?
I think it's a general point we're not very good at, and I think we've talked about this at the the big spring meeting in the past, is we're not very good as a healthcare system, and this isn't confined to the UK, but we're not very good at the healthcare system in giving people useful information on discharge after any procedure, not specifically ERCP. And there's often if things have gone well in the immediate, the procedure's gone well, technically the patient makes a good initial recovery, that then I think is a gap when people do leave the hospital for useful practical information. And that useful practical information also needs to be supported by some way of seeking help if things aren't going well, and trying to seek advice. And I think trying to have some very straightforward advice to people on discharge after a stenting procedure, which details things to look out for, exactly lays out timeframes. You may have some low-grade pain for 48 hours as your stent expands, but it should be controllable with paracetamol. And if it's more severe than that, this is what you should do, and this is who you should ring. And I think that's what we also need to have, is a mechanism for people to actually seek help and advice if they need it, because you can ring, the NHS Direct, or you can go to the local urgent care centre, but in quite highly specialised rare conditions and rare procedures, sometimes the advice you can get from those routes isn't quite as precise as you'd like.
Yes.
Thank you, Helen. I was going to ask a follow-up question to that, or a similar question to that. But I guess just drawing on my own experience, I mean, I've had infections on numerous occasions, and I've have learned after the first and second time that you need to present yourself in A&E and very clearly say, I have had a fever, I have a fever, I have biliary stents, this is likely to be biliary sepsis. And I've always then found that getting fast-tracked through to the system rather than waiting in a waiting room for a very long time and getting straight onto antibiotics has been incredibly beneficial. So just urge people who do experience those types of symptoms to be really clear at the reception desk and a triage that, you know, they have stents and these are common complications and are likely to lead to some form of infection. I wonder whether some form of like card, you know, you often get a card when you're on chemotherapy and immunotherapy that sets out the side effects that you're likely to have, phone number that you need to call, but also you can present it at a desk and it very clearly signposts that you need to seek quick help. So that's just an idea from my perspective. But I guess my question, and it's not really about stents actually, is there presumably there are sort of patient factors that mean that while stents are needed, stents aren't possible. And in those circumstances, and you know, what are some of those common ones? And in those circumstances, what are the alternatives?
So, I understand your question is that if someone's got obstruction of a bile duct, but it's not possible to place a stent, is that the sort of scenario you're thinking about? So, this is when we sort of come back to that sort of discussion of PTC versus ERCP. Normally, one way or the other, if there is a major duct obstructed, it can be stented by PTC or by ERCP. One or other technique works. As Sheela touched on in her talk, there are some, and it wasn't really within the scope of the discussion this evening, we've now got some EUS guided, endoscopic ultrasound guided techniques we can use as well to puncture the bile duct through the stomach wall or through the duodenum that give us even more scope to deal with these situations in people who have complex anatomy, say after surgery, which can, you know, when the stomach and duodenum have been removed or rearranged. So there are new techniques. I mean, in most situations, if literally from a plumbing point of view, if there's a blockage there that you can get that needs a stent, you can normally get a stent into it. I think I don't know whether the scenario you're talking about is when multiple small bile ducts are affected, and so it's not possible just to pick that one or two ducts that putting a stent in will relieve the jaundice. And that's a very hard situation. So sometimes we find ourselves in a situation where sadly someone has a cholangiocarcinoma that's so extensive at diagnosis, particularly hilar cholangiocarcinoma, that you could put 6, if you could, and sometimes you can or you can't, even if you put 6 stents in there, you still wouldn't drain enough liver for the bilirubin to come down and have a meaningful effect. And that's because if the tumor has grown up those bile ducts and infiltrated all those bile ducts, you can put all the stents in and you just can't drain the liver. And that's either way, PTC or ERCP. And that's a very difficult scenario because the treatment options there are very, very limited. But that's a small minority of cases, but it definitely exists. I think, Kevin, and also one of the points you were making about, I mean, you seek help where you can get it, and if you're not getting the right answers, if you're still worried, if the people looking after you, if your family, your caregivers are worried, yes, you go to the emergency department. And I think there's a big drive, you know, to improve the management of sepsis generally, and that's what we have to remember is that cholangitis is effectively going to lead to sepsis, and sepsis is life-threatening and it requires immediate action and immediate IV antibiotics. Attend with a copy of your ERCP report or a recent clinic letter that lays out what's going on. Even if you've got it saved as a PDF or a JPEG on your phone, you know, as you say, you show it to the reception desk. You say, this is what I've got. I've been warned that I'm at risk of infection. I'm at risk of sepsis, and use those sorts of phrases to make it clear what the risks are, and that should trigger the attention, as you found, the attention that you need.
I think that's a really valuable point, Chris, and we would say to people, and Kevin, I feel a new project coming on. We're going to have to think about producing a card for our patients. But when you get those shivery shakes and everything, immediately seek help and use the words, I have a stent, I have these symptoms, I feel I may be getting biliary sepsis, and just use those words to get the attention. I know we're possibly pushing for time before we go to the questions, but I've got something that I'd like to get your thoughts on, Chris. So we've talked a lot about how stents can block stents can, and then we can get these awful infections. And this is one of the things that Sheela and her team are working on so hard, to find ways to improve the use of the stent, keep them patent for much longer. But there used to be quite a lot of thinking around ways to maybe prevent these sorts of things happening in the first place. And that was with the use of a drug called ursodeoxycholic acid, which helps bile to, this is my understanding, helps bile to flow a little more easily. And combined with taking sort of low-grade antibiotics prophylactically, that sort of staves off the onset of block stents and infections. And I just wondered, has that all fallen out of use, or are there contraindications for that now?
So the short answer is yes, it has fallen out of use, and I think I'll answer the antibiotic question first. So the problem with using antibiotics in any dose, medium or long term, is the emergence of resistance. And if there's anything worse than having a highly sensitive bacteria in your biliary tree causing sepsis, it's having a highly resistant bacteria in your biliary tree causing sepsis. So there are very limited situations where we have patients who have got recurrent biliary sepsis, in the same way that patients who get recurrent urinary sepsis will sometimes go on to cyclical antibiotics. It can sometimes be used. Using that in a patient presumptively, where actually they may have, because of course we're focusing on the complications, and actually a lot of patients with stents don't get major complications. And yes, a stent will block at some point, but it's not necessarily the roller coaster that some of the examples that are unfortunately common, but when we're talking about this evening, but not everyone has that experience. And to give those patients presumptive antibiotics on a long-term basis would risk the side effects of those antibiotics and the emergence of resistant bacteria. In terms of ursodeoxycholic acid, so this is a drug that has proven to be of benefit in some liver diseases. In that how it works is it's actually a bile acid, and it's one of the less inflammation promoting bile acids. And essentially, if you take it, it displaces the inflammation promoting bile acids, and they're displaced out of your biliary circulation, and you have a nicer quality of bile, if that makes sense. And there's evidence that can slowly dissolve gallstones over the course of many years. There's evidence it can reduce or stop the increase in size in gallstones, and it does help with some inflammatory liver conditions. But its utility in preventing stent obstruction, I think, has not ever been proven. And I think, in the absence of very clear clinical evidence that it is of benefit, I think it would be a big commitment for the patient to be on those types of drugs as an open-ended thing. So I don't think there's evidence to support it, and I think that it would not be something you'd want to try speculatively. But I think in terms of potential harm, I think there's less potential harm with that strategy than there is with taking continuous antibiotics.
Okay.
And as Sheela sort of very eloquently described, I think that the strategies of that study, the components of that study, are around trying to stop biofilm formation, which we know is really, really important, is going to probably pay more dividends. I mean, there are some factors you can't really control for. Some people, they just get reflux of food up their stent, and bits of food get stuck there, and that causes inflammation and partial blockage of stents, things like that. But again, it's the biofilm formation that I think is going to be particularly interesting to see how these sorts of this study sort of develops in that field.
Yeah. Thank you very much for that. That's good. So I now know how to answer people when they ask these questions, because, we get very educated patients coming to us now asking quite involved questions, and that's a very clear answer for us. Thank you.
I think one of the challenges, again, we've discussed it at the meeting and offline, one of the, it's a great challenge to have, but with some of the new drugs with immunotherapy coming through, people are living longer, and that's fantastic. And that's a challenge to us, because we need to get the stents to last longer. Because and I think that's it's a new challenge. And I think that really is driving, you should be driving the work that Sheela and other people are doing, because we need stents that are going to last 2, 3, 4, 5+ years. That's what we'd have ideally.
Yes, I think Sheila's work is pretty vital and very well timed. Well, we could have had it sooner, but and I'm assuming it's going to be positive. So on that note, Sheila, how long would you think this is going to be, assuming everything goes wonderfully, before we can actually trial it in a human being?
That is a very tough question, given where we're at the moment. But I would say it will definitely be beyond 3 years, because it was going to take us a minimum of 3 years to put these different components together. And then after that, I guess it would be considered as a medical device. So it may then be able to be tested in people a little bit faster than if it was a completely novel just drug, just a novel therapeutic. Yeah. So because of that, I think it could be about 4 or 5 years' time, I would estimate.
Okay, we'll watch this space then. Thank you.
And I am just gonna, I think, move us on to the next part of the webinar, if that's okay. I'm just keeping my eye on the time. We have had a couple of questions in from home, so if it's okay with you, Helen, I will move us on.
Yeah. Thank you.
So we have a question from an audience member. I think this is probably best for you, Chris. Is if a chemotherapy drug is included in a bile duct stent, is the intention for it to act only locally on the tumor at the site, or could it also have a systemic effect if multiple tumors are present?
I think it's probably best fielded by Sheela, but I mean, my initial answer would be that I think this would be local effects, rather than having a systemic effect. And the advantage of this strategy would be that potentially you can get a much higher concentration of the drug at the site where you want it, which is in the tumor, rather than putting it into the systemic circulation, it going to every tissue in the body. The appeal, and it's a theoretical appeal in this situation, is you can give very high doses of drug locally to the tumor rather than it being something that goes in the whole body. But the disadvantage is, I don't think, and Sheela will correct me, this isn't going to have a remote effect on metastases that are deposits that are a long way from the primary tumor.
Exactly. Yeah, exactly that. But the idea is that, yes, it's a local treatment to hit the primary tumor that's growing in the vicinity of the stent, and then you'll get higher doses. Often, one of the reasons that the drug that we're looking at, we aren't pushing it particularly systemically, is that when you take it orally, that particular drug can easily get inactivated in the gut. So by placing it directly in the bile duct, it's where it needs to act. So it should be able to have an effect immediately. Whereas if you took it orally, half of it gets inactivated. So very low dose then gets finally to the bile duct. So hopefully we're going to avoid those problems.
Brilliant. And thank you for both of your answers. We tag teamed it in the end, which is good. And then I think this question is to everyone, really. So what food should be eaten or not eaten after having a stent inserted? So maybe we'll start with you, Andy, or Kevin on this one, and then we can go to either Chris or Sheela. So foods to avoid and foods to lean towards.
I think from my perspective, it was...
Sorry, Andy.
Sorry again. From my perspective, it was just keeping foods sort of fairly light, avoiding meats, the heavier meats, beef, lamb, and just trying to keep a very sort of vegetable soup type orientated diet for a couple of days, and after that, things sort of picked up.
It's a very, very similar experience for me. I mean, 3 years, obviously, once the stents are inserted and you start get your appetite back, taking things very easy. and in small portions regularly, that type of thing. But even 3 years on, I still avoid very fatty foods because I feel they, personally, my personal experiences, they tend to cause me challenges or problems. But I think it's a really great question because I've never been given any dietary advice around how, or more broadly, how to manage my stents and to reduce the chances of there being blocks. So I'd be really interested to hear Chris's view.
So yeah, thanks very much. So I think firstly, I mean, in the immediate phase after an ERCP or PTC, particularly in the situation Andy found himself in with pancreatitis, then, but even in the absence of that, then a low-fat diet is what we would recommend to patients for just 48 hours after an ERCP. We want people to get on and start eating sort of the evening of their procedure, but we normally recommend low fat. So no, sort of not going straight off and having fish and chips. Not that anyone fancies it, but fish and chips or steak and chips. It's trying to keep it low fat to start with. That's just for initial 48 hours. After that, there is not really much clear evidence. As I've already talked about, a lot of patients, because of jaundice and also tumor effects, the biochemistry of the tumor and the effects it has in the body with the cytokines it releases, other chemicals it releases, they find they have a change in their appetite. They lose their appetite, and also what they fancy changes. So things they've loved for years, suddenly they've just gone off with lamb, something. I've always loved lamb, and I just can't stand it. And the advice that we tend to give is very pragmatic, which is, we don't want people to go off and start taking a really unhealthy diet and eating McDonald's all the time. But actually, in this phase, when you're recovering from a long period, perhaps of not eating properly, and you've got potentially challenging treatment ahead of you with chemotherapy or surgery, protein is really important. Calories, full stop, are really important. And how you get that is actually not so important as that you get it. So it's what you fancy, eating, and eating those things. I would not encourage a very, very high fat diet after any, biliary or pancreatic issue or intervention. But if someone says, look, all I can face eating is actually all I can eat is cheese and bread and cheese, we'll eat it because it's far better eating that than nothing and losing more and more weight and not being strong enough to have your chemotherapy or have your surgery, which is what the target is. So I think we have to be understanding, we have to be pragmatic. Access to dietitians in the NHS is really very limited. The dietitians within the NHS work very, very hard, but they just don't have the resource and the staffing to keep up with the demand. And everyone with these sorts of conditions should have access to a dietitian and have an hour with the dietitian, but that just doesn't happen. I think another important point is that people are very generous with advice. This is what, this is from personal experience and also professional experience, is that people are always very generous with their advice. They always want to tell you about how so-and-so just ate this or just ate that and their cancer disappeared. There's, of course, now so much on the internet and social media about I did this and I got better. And that's people trying to help, in the vast majority of cases, rather than make money, but it's people trying to help. But that sometimes can be overwhelming for patients. And patients say this, they say, look, 6 different people have told me conflicting advice about what I should eat. And I think that the bottom line is, apart from taking a really, really unhealthy diet, eat what you fancy, eat what you can face, and eat what is going to allow you to achieve your nutritional target for your ongoing treatment. And that's the most important thing.
I think if I could come in there again, Chris, that there is a real lack of dietary advice for those with cholangiocarcinoma, and you're quite right. Those dietitians, nutritionists within the NHS are few and far between, and those who have a specialism in the area that we're talking about are even more rare, if that's possible. We have managed to get hold of a dietitian who actually does work with patients who have had or undergoing treatment for upper GI malignancies and so on. Now, there is a distinct difference in the sort of advice that they will give as opposed to general advice. And I think whilst what you're saying, and far be it from me to go against anything that you would say, Chris, but it is because the bile you know, is acting differently. You know, you haven't got that fine tuning, perhaps when you've had stents done or you've had a resection or something. You don't have that fine tuning that you were talking about early on with the relaxing and releasing of sorry, the closing off and then releasing of those valves and so on. That it does mean, it was interesting to say that the example you gave of people say, oh, I can't eat lamb anymore. That's quite common because lamb is so fatty, and that's why people cannot digest it. And I think it's difficult for people because they don't understand, number one, why things taste different. I think it's their body telling them, don't go for this anymore, this is not good for you. And a lot of people find it's much more understood in those who've had the pancreatic cancers, because they know that they've had the surgery, they're lacking in that enzyme and they will need to take their creon and so on. But sometimes that happens with our cholangio patients too. And I think they're very poorly served when it comes to advice in that area. Quite poorly served in many areas, of course, but you know, in dietary advice, I think that's quite lacking for them. I think, you know, your advice, like when you've been stented and you haven't been able to eat for quite a while, well, yes, it is a question of whatever you fancy, but then you'll learn what you can tolerate and what you can't. And I think you have to adjust your diet accordingly.
No, I quite agree, and I think that's what I would encourage is a pragmatic approach. And you know, I wouldn't want people to eat, you know, a junk food diet, but I think that it's hard enough. Sometimes we've all encouraged people to eat when they don't want to, when they're sick, when they're very sick, and for the patients it's really difficult. You know, you can try and tempt them with the things they've always loved and they don't fancy it anymore, and you have to be pragmatic in that situation, and getting calories in and getting protein in is the priority. And I think that's what I was trying to convey, is taking a pragmatic approach. Because otherwise it becomes almost a mental block to eating in some patients. I think that I've lost my train of thought now, but I think one of the in terms of access to dietitians, yes, it is very difficult. Often, you know, and it's not. This isn't a justification of it, but that often oncology and cancer services have specialist dietitians embedded in those services, and often access there is better than it might be on a general ward or in a general gastroenterology or surgical outpatient. So that's just, if people are trying to access help with that side of things, you can sometimes access it via the oncology service when if you're going up for appointments there. They seem to be somewhat better served, but dietetics is really difficult throughout the NHS. And as I said, you know, everyone with this sort of diagnosis should have an hour with a dietitian, you know, up front, and you know, follow up as needed, and that remains a distant aspiration, unfortunately.
So would you say then that it's sort of really up to the patient to ask their oncologist, can you arrange time with a dietitian for me?
Again, I'd hesitate to put the onus on the patient, because it shouldn't have to be. It should be offered. But I think that, yes, I mean, I think that it's something, speaking to the CNS or the Cancer Navigator or the Macmillan team, whoever the sort of around supporting that service, to help you access those sorts of professionals. And they exist. They have dietitians in every cancer service in the country, and you know, the provision will vary. But I think that definitely it's within the patient's right to ask that and inquire and say, how do I access that? And I would encourage people to do so.
If I can just turn it back, and I know we are beginning to get towards the end, but just to both Andy and Kevin, and say, were you ever offered dietary advice? And go to Andy first.
Yes, I was, but it wasn't. I didn't find it particularly helpful. It was very generic, and whenever I asked any questions around what I was being told, they just repeated what they'd said previously, and I actually found the internet more useful than I had. It was. I think I was just unlucky.
Kevin, what about you? Have you had any?
So I also have, and I requested it through. Well, actually, during a stay for biliary sepsis, I was introduced to a dietitian. But again, the advice was very general around maintaining a healthy diet, and more or less the sort of information that you would give the general population rather than things that were specific. So I would encourage people to ask actually once they have, be having interactions with oncology, stays in hospital, always worth asking, because you don't know whether it will benefit you or not.
Well, absolutely. I would just say that we do have on AMMF's website, we do have very specific information about, diet for cholangiocarcinoma patients, and in fact, a presentation by a dietitian, specialist dietitian. But it just, once again, in this whole area, the patient has to be their own best advocate always, don't they? And it's so hard when you're feeling so ill to do that, but unfortunately that's what we all know we have to do. Right, I'm looking at James to see how we're doing.
You can see the eyes, Helen, looking towards me. Yeah, I think we're perfect on time now, so we will do a quick close now if that's okay with our speakers.
Yes.
So I just want to say a big thank you to the sponsors for this event. Although they've had no direct input on the content, they are working to improve the lives of those with cholangiocarcinoma. Our next webinar will be in January 2026, believe it or not. And the topic is yet to be decided, but I mean, following on from the discussion today, as you can see here, it is likely to be on maintaining a healthy lifestyle and a nutrition plan to support treatment and recovery. So, Helen, that does seem like a really good topic for the next webinar, but that will be on the 21st of January. More information will follow shortly, so don't forget to register when that becomes open. And then lastly, I would just like to thank all of our speakers, for your time this evening. It's been invaluable. A reminder that the webinar will be recorded and available on AMMF's website in the next couple of days. And then I will hand it over to you, Helen, if that's okay, to do a close.
Yeah, well, just to say thank you to Dr. Wadsworth, Professor Jayaraman, to Kevin and Andy for being so helpful, providing such great information and answering the questions. I think I've learned stuff tonight that I wasn't so aware of before. So hopefully everybody who's joined us this evening will feel better informed than we were at the beginning. And also I hope that everybody feels that there is good research going on, and we are hopeful of what that might bring for us in the future. So thank you to all of our speakers and our patient advocates, and of course thank you to everyone who attended this evening and those of you who have provided questions for us. So again, just to remind you, you will be able to see this webinar again. It will be up on our website as soon as we can get it there. We will let everybody know via social media as soon as that is available. And as James has said, this is not the end of our series. There will be more. So again, look out for the details of the next webinar, which will be coming up early in 2026. So thank you very much, everyone. Thank you.